Hello everyone, I am Dr. Sambhav Shah and today I will be discussing a video on full endoscopic cervical discectomy. In the cervical spine, I use the full endoscopic approach mainly for posterior access. I do not do anterior cervical endoscopic approaches as I don't see much of advantage over our conventional anterior cervical approaches. However, in cases where a patient has radiculopathy with a far lateral disc, a stable spine, or it could be a compression of the cervical nerve from a disc ossified complex, and this compression is lateral to the nerve or in the foramen, then the posterior cervical discectomy or decompression has definitely has way more advantages than going in from the front and doing a ACDF. The case we are going to discuss today is of a 45-year-old female with severe left arm pain for 2 months. She failed all conservative management in the form of physiotherapy. She did some local massages, and she also had a temporary relief after a C6 nerve root block. However, the pain relief was only for a few days, and the pain came back. The SAG MRI showed a left-sided C5-6 disc prolapse compressing the left C6 nerve. It is very important to also study the axial MRI scan because this is where you will see the exact location of the disc, and it's also helpful for preoperative planning. In this MRI, we can appreciate that the disc is just below the lamina facetal junction. So my endoscope has to dock at this lamina facetal junction. As you see in this image, that this is where my target docking point should be, where I will be able to appreciate the lamina, the superior lamina, inferior lamina, the interlaminar space, and a part of the facet in my direct vision once I dock my endoscope. It is important to note that the surgery we execute, irrespective of which method we use, either open, tubes, or full endoscopic, the end result is the same. Our aim is to remove that piece of disc without removing minimal bone. And when we are doing an open surgery, we have access to the full anatomy. You do have to expose the upper lower lamina. You do have access to a wider vision. However, the more minimally invasive we get to, the more difficult the anatomy gets. As you see here in case of a tube, you can still appreciate a wider area when you dock your tube because you're working through a bigger channel. However, when it comes to an endoscope, you are using a 4.1 mm or a 5.7 mm working channel scope. So the amount of area which you are going to see is going to be much less as compared to the other techniques. And hence, docking the endoscope at the right area and confirming the anatomical landmarks is of the key. Now I will just show you the steps of the surgery on this model. That's the C5 lamina, the lower one is a C6 lamina. So we are docking in this area where we will appreciate the lower half of the C5, the upper part of the C6, and the facetal junction. Once we have appreciated this area and once we have docked, we start burring. The burring starts from the C5 lamina going laterally until the facet, just the medial part of the facet, and then if required, you may burr a little bit of the C6 lamina. The positioning is in the prone position. The monitor is in front of you. The C-arm comes also from the opposite side. You have to make sure that the anesthetist has docked her station at the foot end. You may use Mayfield or a horseshoe in these cases. You can also keep the neck in a flex position, which opens up the interlaminar space, and you may require less resection of the lamina in order to create the space for your instruments to go in the canal. Next, you get the C-arm in the field and you mark the laminofacetal junction in AP. Please remember, we don't need to square the vertebra. We keep the C-arm the way it is. We do not square, as that may change the entry point of your incision and make the surgery much more difficult. Once you mark the laminofacetal junction, then the C-arm is taken in the lateral position. In the lateral X-ray, the spinal needle is then inserted at the disc level, which we are going to be operating. In the cervical spine, it can get difficult because of the shoulder, so make sure that you pull the shoulder down or also take some preoperative checks to see that the disc level is well noted in the lateral X-ray. The working cannula of the endoscope is then inserted over the dilator, and then the whole system is introduced and the surgery starts. So once the endoscope is inserted, then the soft tissue is cleared. We have to now identify our anatomical landmarks. So as you see here, this is the C5 lamina. The soft tissue dissection has to be carried out laterally to see the facet. And once you identify, then the boring starts, boring this part of the C5 lamina and the medial part of the facet joint. Once boring is done and the bone is thinned out, Kedison punches can be used to remove the part of the lamina. Our aim is to remove a little bit of the C5, the medial facet. Here I'm using an oval burr with a side protection. You must have noticed that you can already see the part of the dura over here, and the flavum has already been removed, and that is also partly because of the burr. So we have to be very careful when you are burring that you don't damage the dura. Uh, Now, the beauty of the endoscope is that I have rotated my endoscope laterally to see underneath the facet and near the facet and to remove the part of the facet now which is overlying the nerve root, and this is where exactly my disc is going to be below this bone. This is the lamina facetal junction as we saw on the MRI scan. So once we remove this bone, we will start appreciating the C6 nerve, and as you see here, we are seeing the whole C6 nerve in its totality, and we have found the disc here. And once the disc is removed, suddenly you will notice a gush of blood, and that's the epidural bleeding. And it is quite common in this area as the epidural, there's a lot of epidural vessels. In this case, there were other fragments also lying underneath the nerve, which we're using with this forceps and removing them. And once these fragments are removed, the whole C6 nerve has been completely freed, right from where it's coming out from the central cord and exiting below the foramen. The radio RF probe is also used to probe for further discs and to check whether the nerve root is completely free. And once the nerve is freed, you can sometimes appreciate the pulsations of the nerve as well, which tells you that this nerve is free. These are the four fragments that were removed, and the incision size was less than a centimeter. The patient was mobilized immediately after surgery. Within 2 hours, she was walking and she was discharged the next day. This is just a post-operative CT scan just to show the amount of bone removal which we need to do. So as you can compare it to the opposite side, there's hardly any lamina or very minimal medial facet resection also in order to remove this piece of disc. So a lot of times we are questioned that you remove a part of the facet, the spine may become unstable. However, the amount of bony removal is very, very minimal in endoscopic spine surgery. The same thing if I had to do with tubes, the amount of lamina removal, the facet resection would have been significantly higher. However, in endoscopic spine surgery, the amount of bony resection done is just to create access to go and remove the piece of disc. And because the instruments are so fine, the amount of bony removal is much less.